Distinguished chairpersons and colleagues, I'm going to present an unusual case of venous thromboembolism, probably not very unusual for a few, but some important messages on the way. So this is a 36-year-old gentleman with a history of acute onset breathlessness, which he'd been having which he had about 1.5 years back, and was diagnosed as a case of pulmonary thromboembolism, and was thrombolized outside but did not have enough recovery and was being treated with diuretics and acetrom for the last 1 year. When he came to us, he was symptomatic, on no treatment, and had dyspnea and NYHA class 2. When he had the primary findings were a sinus tachycardia and a loud P2 on examination. ECG was showing right bundle branch block, chest X-ray was unremarkable, and the lower limb venous Doppler as well as the CT venography were negative for DVT. But his CT chest showed pulmonary embolism, and he was taken up for, this is his echo when he came to us in the first visit, and you can see that there is dilated right ventricle here, and suspicion of a thrombus in the MPA.
There was a tricuspid regurg.
Yeah, there is. And his pressures were nearing 100 when he came to us. So if you notice, the date is 12th of January when he came to us. And we took a detailed history, and the patient's history, he came up with the fact that his father's younger brother and his first cousin also had similar history of pulmonary thromboembolism. So we investigated him for any predisposition based on what is recommended by the European guidelines, and all these factors, whether any predisposition were present or not, were taken into account. And obviously he seemed to, by history itself, he seemed to be having some kind of a thrombophilia. But when we investigated him on these lines, trying to find out whether any of these factors were present as a primary cause, we came up with the fact that he had hyperhomocystinemia. And anyway, he underwent surgical embolectomy and endarterectomy in January 2009 and had a remarkable recovery with PA pressures falling almost up to 33. He was put on acetrom and to maintain the INR between 2 and 3, and histopath showed thrombi. Now, he came 2 months later. In between, he was fine, and he underwent a routine ECG and an echo, and ECG still had sinus tachycardia, and echo is shown here.
So that's the RA clot.
And so he was readmitted. We advised that this requires thrombolysis or the surgical removal, but he did not agree to either, and he said that please treat me conservatively. I am not interested, because when you explain the consequences of what could happen due to thrombolysis, he was afraid to go for it straight away. He said, please treat me conservatively, and he was definitely not interested in the surgery to begin with. And so we gave him heparin as much as, trying to maintain it with the APTT about 2.5 of the normal, of the control. And after 4 days, and we did CT chest and CT venography in that patient, which did not reveal any deep vein thrombosis or pulmonary embolism. Now, this is his echo on day 4, and you can still see that there is a large RA clot here. The date is 17th March. Here is another view, 17th March. There is still a large RA clot which persists, and hardly any TR. The PA pressures were quite normal actually, around 30 to 40. So the dilemma was that now we had to go for thrombolysis versus surgical removal, and thrombolysis was chosen simply because he was not interested in surgical treatment. Now, we thrombolized him with RTPA 100 milligram over 2 hours and started heparin the moment PTTK fell below 80 seconds. And this is the echo which now you can see on day 19th, 19th March. Look at this large RA clot persisting still. So there was actually failed thrombolysis on day 5. So now what? I think we are left with only one option, which is to go for surgical removal, and he underwent anterior thoracotomy and clots were removed, and they were sent for histopath, which came out as thrombi. If you notice, these clots are long, serpiginous, highly mobile, which basically simulate the venous channels. You know, the veins are long, tortuous, so the thrombi which come out of them are also serpiginous and tortuous. And this is, when you look at these masses, it is probably right to assume that they are likely to be thrombi, which was proven in this case. So during the recovery phase, he underwent infrarenal IVC filter positioning, and then we started him on, we overlapped acetram with heparin and target of INR. The moment INR 2 was achieved, we stopped the heparin and continued him on acetram and made an uneventful recovery. So, and he was sent on acetram. We added aspirin as an additional precaution and folate for his hyperhomocystinemia. So there were certain unique features and dilemmas in this case which I'm going to highlight. First
Dr. Agarwal, can you make it quick? You have just about 2 minutes to go.
Yeah. So there is hyperhomocystinemia here, which patient had, and a strong family history of pulmonary thromboembolism. There are important questions things which one should remember, and that is we should routinely search for factor V laden in these cases, hyperhomocystinemia and antiphosphorylated antibodies. It is important to remember that protein C and S are low in patients with ongoing clotting. Heparin, if you have given it, will decrease the levels of AT3, and warfarin will decrease the levels of protein C and S. So if you get these tests done, they're likely to come out as negative or may not be the right results. Secondly, primary hypercoagulation disorders are to be sought in patients who are less than 40 years of age with positive family history and recurrent VTE. No advantage in searching for occult malignancies. Now, there is important, these right heart thrombi have been shown to be, most of them are located in the right atrium and have very, very high mortality if left untreated, almost 80 to 100% mortality in these cases. And overall mortality in these cases is about 28%. Now, the optimal management in these cases is not clear because there are no randomized trials. There are about 3 studies which I'm going to quote very quickly, which is the initial reports were in 1989, which showed that actually heparin was equivalent to thrombolysis or surgery, but this was way back in 1989. And the more recent reports are from CHEST 2002, where 170 cases retrospective analysis showed that most of these cases had associated massive pulmonary emboli, and the overall mortality was 27%. The mortality was least with thrombolysis. It was actually 100% if you just gave heparin, and it was about 11% with thrombolysis, and better than the surgical embolectomy. The surgery had its own complications or delays of at least few hours, general anesthesia, the bypass was required, and also there was inability to remove the coexisting pulmonary thromboemboli beyond the central pulmonary arteries. The recent evidence is from the ICOPA series, where they've shown that thrombolysis is the method of choice with about 14-day mortality of 20%. And in the latest 2005 CHEST, they've shown that most of these patients, if you thrombolyze them, then the clots keep for about 24 hours it takes for most of the clots to dissolve in these cases. So one should not really, one should keep scanning them for say about 24 hours to see for the evidence of dissolving. And the IVC filter, of course, it's going to be taken up in the next session, so I'm not going to go into it. So the take-home message is that the right heart thrombi have very high mortality if untreated. It confirms the presence of pulmonary thromboembolism in clinically relevant setting, avoids unnecessary pulmonary angiography or contrast studies. Definitive treatment should be initiated as soon as possible. Thrombolysis and surgery are both effective options, but should be decided on individual basis, and only anticoagulation is ineffective. Associated patent foramen ovale with, which could result in paradoxical embolism is a good ground for surgical intervention, especially if you can see the straddling of the thrombus across it. And it also contraindicates the use of venous catheter, Swan-Ganz, and jugular IVC filter. So I think this case will probably be taken in the light that everything in this world is relative, and I think we have to take the appropriate decisions based on the circumstances. Thank you.
Thank you, Dr. Agarwal. We could allow just one or maybe two questions. This is unusual, getting a thrombus in the right atrium. In fact, we all handle so many DVTs, so many pulmonary emboli, but getting a thrombus in the right atrium is unusual. And I think all of us learned a different way to address the right atrial thrombus.
Can I have one comment, please?
Yes, sure.
Yeah, I had one patient who had right atrial thrombus, and I was doing echo. He got cardiac arrest.
It got?
He got cardiac arrest.
Yes.
And he could not be revived. Anything I could have done that particular time? He just collapsed. After I massaged for half an hour, gave TPA, but nothing could have been done. He died.
You have the video?
I have not got it now, but I have with me that huge clot was there. After about 5 minutes, he got arrested.
I had a similar clot in the left atrium. The entire left atrium, the ball was moving. Like you would hit with a table tennis racket. It used to get hit by the mitral valve, again used to go all over. And by the time we shifted the patient from echo to the wards, the patient was dead. So they started saying that you kill the patients on echo table 2 now.